Good afternoon. I'm Dr. Mike Kwan of Princess Margaret Hospital. I'm going to talk about COVID-19 in children. I'm delighted to speak with Nigel in these occasions. I wish to send my best regard to the infectious disease team of Royal Children's Hospital, Melbourne. This photo was taken in 2014 when I visited the team at that time. And Nigel came to Hong Kong in 2017 in our infectious disease conference. Up to the time of the recording of this video, we had 1,021 pediatric COVID-19 infections in Hong Kong, 8.2% among the total infected populations. And for the audience information, since 16th of November, the Hong Kong Hospital Authority Infectious Disease Centre and North Lantau Infection Control Centre are designated centre for COVID admissions in Hong Kong Special Administrative Region. And all our staff need to undergo regular every 3 days staff nasopharyngeal swab and full swab PCR screening, just like what have been done to me in this photo in the staff testing centre. And we published our experience in managing the COVID-19 pandemic in the Hong Kong Journal of Pediatrics. And also Gilbert published a paper on the clinical characteristic and transmission of COVID-19 in children and youth in the JAMA Network Open during the 3 waves of outbreaks in Hong Kong. And our experience during this 3 waves, we analyzed 397 children and youth with SARS-CoV-2 infections. Around 40% were asymptomatic. 91.2% reported having a contact history, and 90% were from family members. And fever, cough, sputum, and runny nose were the most common symptoms. And among them, 3 individuals with domestic SARS-CoV-2 infections in our study reported to be schoolmates in close contact. There was no report that teachers had transmitted COVID-19 to their students. And 3 individuals with complicated illnesses, including autoimmune hemolytic anemia, the pediatric immune inflammatory multisystem syndrome, and COVID-19. Other symptoms including anosmia, ageusia, change in exercise capacity, and also fatigue. The conclusion of our study is nearly all children and youth with COVID-19 in Hong Kong had mild illnesses, and household transmission was the main source of infection for this individual with domestic infections, and the risk of being infected at school was small. And Dr. Mack published the anosmia and ageusia, actually not an uncommon presentation of the COVID-19 in children in the Pediatric Infectious Disease Journal, and we found that these symptoms were maybe the only symptoms and also the presenting symptom, and also they may last for 6 weeks. Actually, some of my patients, these symptoms last for around half a year and even longer during my follow-up. And another important symptoms is COVID-19. Those are itchy, tender, acral lesions, appear as purplish, flat, and dry lesions. Those are tender on palpations, and characterized by the reddish blue discoloration of the extremities. And this case already accepted as publication in scientific articles. Another important syndrome is pediatric inflammatory multisystem syndrome, what we call the MIS, the multisystem inflammatory syndrome. I think most of you heard in the recent news 5 cases from Singapore. In Hong Kong, we got 1 case, a 10-year-old Caucasian who diagnosed as COVID-19 in mid-June 2020 and admitted 4 weeks later with prolonged fever, and symptom and sign resemble a Kawasaki disease like bilateral conjunctivitis, red and cracked lips, strawberry tongues, and branchable erythematous rash, and the lowish blood pressures. And you can see the non-exudative conjunctivitis and perilimpic sparing, red and cracked lips, and red strawberry tongues, and also branchable skin rash. Those fit into the criteria of a diagnosis of the MISC. We participated in the best available treatment study led by Professor Mike Levine of the Imperial College of London, and we wished to find the best care recommendation on a treatment option for these children. The paper was published in the New England Journal of Medicine in June. We participate as the BET consortium member representing Hong Kong, authors including Patrick and Professor Lau, and Dr. Kwok, and Kevin, and also Joshua. And we found no evidence that the recovery from the MISC differ after the treatment with immunoglobulin and steroid or steroid alone. And the approach to this syndrome in hospitalized COVID-19 patients, including a detailed history and also the clinical signs and symptoms, they resemble Kawasaki disease or toxic shock syndrome, and laboratory investigation including the inflammatory markers, supportive care including vasopressor or ventilatory support, and electrocardiogram monitoring, and imaging including chest X-ray and echocardiography or cardiac MRI, and if necessary, anticoagulation treatment or immunomodulation treatment. So in summary, this condition happens in a low percentage of children, characterized by Kawasaki disease-like features with severe inflammation in critical organs, happen weeks after the infection by SARS-CoV-2 infection, and it is a different syndrome compared with Kawasaki disease, and most but not all children will recover, can be treated with steroid or other inflammatory drugs. And in my experience, children being under quarantine or those children whose parents being detached from them, they suffer from severe anxiety, psychosis, depression, and also some may have suicidal tendencies. And so the frontline physicians must be aware of the psychosocial need of these quarantined children. Thanks to the playwright, they prepare many materials for my patients and helping them to tide over this period of crisis. And thank you to playwright. And how the COVID-19 affects children and adolescents in the short and long term. In Hong Kong, currently we have around 56,000 students with special educational needs in public school, in which many got ADHD and also ASD problem. And children and adolescents, particularly those with learning difficulty and ADHD, they face big challenges with online learning during the school closure related to this pandemic. A study by Professor Winnie Cho, and also Professor Patrick Yip, we studied the vulnerability and resilience in children during this COVID pandemic. And this is a large-scale cross-sectional population study with children aged 2 to 12 years of age. We studied around 29,000 Hong Kong families by questionnaire. And we found that increased risk of the hyperactivity, inattentive symptoms, and other behavioral problems during this pandemic, and most significant among children with special educational needs, because they are highly vulnerable and greatly affected by interruption of the rehabilitation training and also medical care. And also, mind you, child abuse, child neglect, and domestic violence are on a horrendous rise at the time of this pandemic because of the markedly elevated parental stress. And also myopia. In this study, we found that the incidence of myopia was markedly increased because of the lifestyle changes in the school children. So the eye care professionals, policymakers, educators, and parents, we need to have a collective effort and remind ourselves that this is a potential public health crisis as a result of this pandemic. So vaccination was available in the form of the mRNA vaccine in May this year. In Hong Kong, since 10th of June, the age of the COVID-19 vaccine lowered to 12. And at that time, the BioNTech vaccine is the only vaccine available. And we know that myocarditis, especially following the second dose, are reported to be a known complications in this population, especially the younger male adults and adolescents. Please refer to my Child Sim talk presented on 13th of June this year. You can click on this link to refer to my Child Sim talk. And the potential causal relationship between the mRNA vaccine and myocarditis has been suggested in the mice model. So at the same time, we advocate and also appeal to the child carer and the children to receive the vaccine for cell protection for their physical health and long-term psychosocial development in this consensus statement, and also in this scientific publication in the Hong Kong Medical Journal. And also, we form a working group to detailedly work up this complication after the mRNA vaccination. You can see this investigation protocol for acute pericarditis and myocarditis after the mRNA vaccination. And actually, every cases will inform me. You can see my phone number here. And we have a detailed workup, including the demographic features and whether they receive 1 or 2 doses of the vaccine. Also have a detailed workup of the ECG, chest X-ray, echocardiogram, cardiac MRI of every cases. So every cases will inform me and have a detailed workup after they receive the COVID-19 vaccine, mRNA vaccine. I would like to present one case to you. A 17-year-old young man received the first dose of the BioNTech vaccine on 22nd of August, admitted around 5 days later to PMH with multiple somatic complaints like central chest pain, the pain score 6/10 with no radiations, and dizziness and headache, low back pain, abdominal pain, and bilateral hand tingling sensation. And after admission, he developed multiple signs, including urticaria, generalized branchable erythroderma, bilateral conjunctivitis, sore throat, headache, and also abdominal pain. This is a timeline of his symptom. He also got dysuria, painful genitalia, and also right TM joint tenderness. You can see the clinical photo, the branchable skin rash, and also the bilateral conjunctivitis with perilimbo sparing. And also the raised inflammatory markers like fibrinogen, ESR, the NT-proBNP level, despite he got a normal troponin I level. And the impression he actually got the multi-system inflammatory syndrome, but this is not an MISC because this is after the vaccination. We call this an MISV. And regarding the SARS-CoV-2 antibody, his RBD antibody was positive, but the NP antibody was negative. This is understandable because this is after the BioNTech vaccinations. So we treated him with the methylprednisolone with 3 doses. And fortunately, his symptoms all subsided after the first dose, and with desquamation and discharged uneventfully. The cardiac MRI showed that he got features of myocarditis, and we reference to the original and 2018 Lake-Lewis criteria. So we performed a study and also written an article regarding the epidemiology of acute myocarditis and pericarditis in Hong Kong adolescents following the mRNA vaccinations. This paper was accepted by the journal Clinical Infectious Disease a few days ago. Now, this is a population cohort study. We recruit all the adolescents between 12 to 17 years old after the COMA3 vaccinations. Those were monitored under the CARE program, the Adverse Event Response and Evaluation Program, a very robust pharmacovigilance system for COVID-19 vaccine. And all cases receiving the vaccine and develop symptoms within 14 days will be reported to the HA, the AR system, Advanced Incident Reporting System, and also the DH and Adverse Event Following Immunization System. And the study period from June 14 to September the 4th. And we allow a cut-off day 14 days after the 4th of September. So the follow-up time will be till the 18th of September. We also have a background rate of this symptom estimated from 2011 to 2020. So in total, we got 33 cases of myocarditis and pericarditis. And you can see 24 were definite cases, and 29, 88% were males, and all were Chinese. And 27, 82% cases developed after the second dose. And they developed symptoms of the pericarditis and myocarditis of a median of 2 days after the vaccinations. And this is a comparison of the incident rate difference of these symptoms following the vaccinations, stratified by gender. You can see in total, the incident rate difference compared with 2020 per 100,000 persons was 18.41. Regarding males, was 32.08. We cannot compare the female because we don't have a background incident rate in 2020. So if we segregate by first and second dose, if first dose in total, there's no significant difference. And for male, the incident rate difference was 5.36. Regarding second dose, in total, 21.11 per 100,000. If you look at the male second dose, it was up to 37.11. So how about if we compare the mean background incident rate in 2011 to 2020? Then the incident rate difference per 100,000 persons in total was 18.37. For male, 32.04, and for female, 4.47. So in conclusion, the Chinese adolescent male have a very high incidence of acute myocarditis and pericarditis following vaccination with the mRNA vaccine, especially after the second dose. So after these results are available, the Scientific Committee on Vaccine Preventable Disease on 15th of September recommend persons aged 12 to 17 years to receive 1 dose of the mRNA vaccine instead of 2 doses. And also as a precautionary principle, the option of intramuscular injection of the vaccine at the mid-anterior lateral thigh should be considered, especially for children and adolescents. So apart from vaccinations, we also recommend the ventilation strategies at school, because it is not practical to recommend school to open the windows because it needs a convective wind current to ensure a good ventilation. We recommend the indoor air filtrations, plus or minus ultraviolet and disinfection. And most importantly, it is necessary to frequent cleaning of the dust filter. So in summary, a message of hope and optimism. Children typically experience mild or asymptomatic SARS-CoV-2 infection. MIS-C and MIS-V is rare but important complication patients, parents, and pediatricians need to be aware of. The COVID-19 vaccination and non-pharmaceutical measures are important. In Hong Kong, we got a robust vaccine-safe monitoring system in Hong Kong. So our parents and patients, our children and adolescents should have confidence in the vaccine. Local international collaborative efforts are needed to help the children and families in need in this COVID-19 pandemic. If you want to know more about the impact of this pandemic on children, you can attend this meeting a few days later. We will address the challenges with a multidisciplinary collaboration, and you can click on this link to enroll. And for the audience information, 1 week ago, the Scientific Committee recommended the use of the Sinovac vaccine for adolescents and children 12 to 17 years of age for a priority deployment, and with a plan to extend to children of a younger age group at a later stage. And at this moment, we recommend the vaccine 2 doses to be given 28 days apart. So I'm grateful to my teachers and senior, Professor Lau, Dr. C.P. Chow, Dr. Bill Chen, and Professor Wing Leung, Dr. Leung, and in this COVID-19 journey. And also my patients. This is my first SARS patient in 2003. She come back to visit us. And also my first COVID-19 patients. This is a thank you card from his family. And also I thank all my colleagues working with me during this COVID-19 journey. 正道同行，使命齊心. We advocate for children's health and well-being. Thank you very much.